Your foot is cold and doctors don't know why. Hi, I'm Kim McNicholas with NextGen MD. We've got Dr. Lily Johnston, amazing vascular surgeon with us from Southern California, and we are talking about aneurysms that may occur in the leg, and your doctor may not detect it. So, it also what more it can tell you about your overall health if you do have one. So stay tuned, stay with us. Make sure you like this video and subscribe to our channel for more great content like this. But let's welcome Dr. Lily Johnston. Thank you. Really interesting topic that we've got today.
Absolutely. Thanks for having me, Kim.
So we had a patient that came to us and said, "Hey, I've been told I don't have peripheral artery disease. The doctor doesn't understand why my foot is cold. They're talking about Raynaud's, and they have sent me on my merry way." We ended up getting this patient a second opinion, and it turns out they have a popliteal aneurysm. Would you give us some more details, explain what this is, and also why some doctors may not be able to detect it?
Sure. I'm going to guess your patient that you're talking about was a little atypical, but popliteal artery aneurysm. So, the popliteal artery is the artery that runs behind the knee. And an aneurysm in this area is actually part and parcel of typical atherosclerotic cardiovascular disease, meaning the accumulation of plaque. And it tends to track with typical risk factors for atherosclerosis. They are most common in older men, so, 60s and up, and they're not terribly common, maybe one in 1,000, one in 10,000. But if you have one on one side, you're about 50-50 likely to have one on the other leg. And you also need to look for an abdominal aortic aneurysm. So you
Oh.
mentioned what else it tells you about your health. And if you are kind of in that classic atherosclerotic risk factor category, you should absolutely be checking for those other things as well.
And describe an aneurysm. What does that actually look like?
I think of aneurysms like an outpouching in a pipe. So arteries are just pipes, and they should, just like a pipe, have straight parallel walls. When we have an aneurysm, there is a weakness in the wall of that pipe, and the pressure that pushes on the artery every time our heart beats, right? That's the blood pressure that gets measured in your doctor's office. That pressure pushes on the wall of our pipes. When they're strong, no big deal. They withstand that just fine. But if the wall weakens, then that pressure over time causes the wall to bulge outwards. And I tell patients that aneurysms are like water balloons. When water balloons are not terribly full, just a little bit of water in them, they are very flexible, very stretchy. You can drop them on the floor, nothing bad happens. When the water balloon gets medium full, the wall is stretched a little bit and they're a bit fragile, but truthfully, even a medium full water balloon is still fairly robust. It's when they get very large that the wall gets very thin, very fragile, and then, you hold your breath, it might pop on you just, by accident without even dropping it. That's when aneurysms are a problem. And mostly when I'm talking about this fragile wall thing, I'm talking about aneurysms in the aorta because interestingly, aneurysms behind the knee, those popliteal artery aneurysms, while technically they can rupture, that's usually not how they cause trouble. Usually they cause trouble by showering clot down into the leg.
Ah. That's interesting. That's what this patient was experiencing, and the doctor's like, "I don't know why you have blood clots going to your toes." "Wait, what?" So, I mean, this patient didn't have uh, any other major narrowings anywhere else in his legs. It
Mhm.
was just right there
Mhm.
behind the knee. Why is it that a patient that has an aneurysm behind their knee is more at risk of having an aneurysm elsewhere, such as in the abdomen or in their thoracic area?
We think it's because the same features that caused weakness in the wall there behind the knee also result in weakness in the wall in the aorta and the thoracic aorta in other blood vessels in the body. So whatever damaged the wall that caused it to be weak, for example, prior tobacco use or nicotine use is a common one,
Okay.
that will also weaken the wall of those other blood vessels.
Also, tissue disorders could have an impact, correct?
Yes, and when we talk about patients who do not have classic atherosclerotic risk factors but have aneurysms, then we switch our mindset and we're starting to wonder, why else would the wall of the artery be weak? Is there an inherited weakness like a connective tissue disorder? The most common examples that we would see under those conditions would be something like Marfan's syndrome or vascular Ehlers-Danlos, which is one of the several subtypes of Ehlers-Danlos syndrome.
It's interesting. We've had several patients with aneurysms at the access site for procedures. Can you talk about what causes those types of situations?
Those aren't actually true aneurysms. They are what we call pseudoaneurysms. And that means that they don't have all three layers of the blood vessel wall. So a pseudoaneurysm is just a hole in the artery that has bled. And so, again, you had a procedure there. They poked the artery with a needle and they made that hole big enough to use the wires, catheters, balloons that were necessary to treat the leg, treat the heart, treat the kidney arteries, whatever they were doing. And when they finished the procedure, they attempted to close that hole in one of a few ways. We have devices that we can use to try to either sew or plug the hole shut. Sometimes we just hold pressure and allow the body's clotting factors to put a little platelet plug in the hole of the artery. But there's a hole that was in the artery, and a decent sized one at that. And if there's any problem with that closure process, then blood leaks out the hole. And under lucky conditions, you could say the rest of the soft tissue, the skin, the subcutaneous fat, the muscle, the fascia will maybe contain that bleeding into a discrete area, and it looks like a bubble. And that's why they call it an aneurysm, because it kind of looks like a little aneurysm. It's a bubble, it's a collection of blood, and it often has continuous flow in it, but it doesn't keep growing because the body has sort of walled it off and contained it. But pseudoaneurysms are a little bit more problematic and require a different treatment pathway and are not necessarily the result of tobacco use or any of the other classic risk factors we talk about.
Is it a surgical treatment that they have to go back in?
There are a couple of ways. Sometimes we can inject a medicine to clot off the blood that's in that little bubble aneurysm area. We need to make sure that that clotting doesn't go into the artery itself, because obviously that is a problem and would block off circulation to part of the leg, and we do not want that. So there are certain conditions or criteria in which a pseudoaneurysm at an access site is amenable to what we call a thrombin injection. Sometimes the aneurysm is too large or it's unsafe to inject it, at which point you might be able to treat it with a stent, or surgery is always another option. Depends on where it is, what caused it, how big the hole is the patient stable? Are they having symptoms like compression of the nerve? The femoral nerve sits right next to the artery, and sometimes people get numbness or compression. Obviously, at that point, we would want to decompress that and make sure the nerve is protected. So all of these things come into play as we're thinking about how to treat a pseudoaneurysm at an access site. And they happen in the wrist too. If you get access in the wrist, we can get one there.
Oh.
I've repaired those. All kinds of things can happen.
So when it comes to the popliteal aneurysm, the aneurysm in the vessel behind the knee, talk about the symptoms. You said that it's similar presentation, right, to typical PAD. Number two, is there any specific trick to diagnosis? Anything that patient should request? And then number three, the treatment options for it, or at what point do you know, for example, in the abdomen or in the thoracic region, you have a certain centimeter, right? You're looking to get to a certain centimeter before you treat and you place a stent as possibly one option. What does that look like for behind the knee?
Popliteal artery aneurysms can be detected on a good physical exam. If the patient has a thin enough leg and you feel a bulge that's pulsatile behind the knee, that's a pretty good indication. You might want to check with an ultrasound. Um, and when I was just learning to do physical exams, sometimes the popliteal pulse is hard to find. So if I could easily appreciate a popliteal pulse, I was very concerned that patient might have an aneurysm, and so I would check all those patients. Not all of them did, but The best way to definitively diagnose this would be with an ultrasound test. So if you're looking for reasons for PAD anyway, you'll likely get an arterial duplex or an arterial ultrasound study, and that should show you, as long as they're taking pictures and not just making pressure measurements. If they're taking pictures, the sonographer should absolutely be able to see an enlargement of the popliteal artery. And you asked about fixing it and the criteria for that.
Yes.
The criteria for popliteal would be greater than 2 centimeters, should be repaired no matter whether there's symptoms or not. And certainly if they're having symptoms at any size. So if there's evidence that small clots have been showering down the leg, if they have compressive symptoms, which is unusual at less than 2 centimeters, but any symptoms, any suggestion that there is clot in there that's causing trouble, if one of the tibial vessels that come off the popliteal artery is occluded, for example, patient has claudication, I would lean towards, recommending repair of that before they continue to shower clot down the tibials and have more problems.
And before we close out this discussion, we do have Heinz that's watching on our YouTube channel. Again, youtube.com/the way to my heart. Subscribe to our channel. And your YouTube channel is Lily Johnston MD.
That's me.
Perfect. Make sure to subscribe to Dr. Johnston's channel as well. Some great content aside from what we do here at the Global PAD Association on her page as well, which is pretty awesome stuff. I think she has a great producer too.
I sure do.
Heinz. Just have to call it Joshua once, twice, maybe 10 times a day. Question from Heinz. Anticoagulants like warfarin, he has heard that they can cause aneurysms. And is this occurrence restricted to just warfarin or other anticoagulants as well? What have you heard?
To the best of my knowledge, anticoagulants do not cause regular degenerative aneurysms like abdominal aortic aneurysms or the popliteal aneurysms that we're talking about. If you have procedures and you get one of these pseudoaneurysms that we talked about, those can be more likely to occur if you are on blood thinners, because
Mm,
sealing that hole shut in the artery that we talked about before is more difficult. The blood is less likely to form a stable clot there, and people can be more likely to bleed after the procedure to get those pseudoaneurysms. That would be regardless of which type of blood thinner they were on. And even the antiplatelet agents like Plavix could create higher risk for those pseudoaneurysms and make them a little more difficult to treat.
And just one final question on this topic. Is there anything that we can do as patients to prevent aneurysms, whether it's behind the knee or whether it's in the abdomen or a little higher?
Yeah, I think you'll probably get tired of hearing me say all this, but maintaining excellent control of your metabolic and overall health risk factors is the best thing you can do. I mean, if you have a family history of weakness in the artery wall, you're dealt a bad hand that way, but we can make sure we don't smoke. We can have an excellent nutritional strategy that minimizes our insulin resistance and minimizes our excess fat tissue in the body. We can exercise and walk, walk, walk. We can
Mhm.
prioritize our sleep and our stress management. We can prioritize our social connection and meaning in life. We can take our medicines as they are prescribed.
Yep.
We can do all of the things that are boring and not very exciting, but that add up every day, just like compound interest over time, and improve our health. And even if you have a problem, should you need it treated, your odds of successful treatment, minimizing complications, will be so much higher if we can get even one of those boxes checked off in our health maintenance.
Fantastic information. Thank you so much, Dr. Johnston. We really appreciate you.
My pleasure. Thank you for having me, Kim.